So I guess we'll present this case now. Now, just by way of disclosure, this is not my case, but I did assist, and I'll share with you a little bit of that. 77-year-old AFib ablation years ago, recurrence of flutter, declined another ablation. Chad's VAS score is quite high and had an issue of bleeding due to falls and GI bleeding. This is his pre-Watchman injection, so you can kind of get a sense he's got a reasonable amount of length there. And this is just deployment of the Watchman device, and it was a 30-millimeter device which was deployed without any real difficulty. And unfortunately, I had to put this together in the last couple of days with a lot of help from our staff. So I don't have the numbers, the pre and post numbers for you, but this is the TEE, as you can see, immediately after the implant. So everything is fine, and the patient goes home and does great.
So, I mean, do you have any other views other than this, like 135 or?
I don't. And again,
okay.
I apologize. This was really a last-minute case because Srini couldn't make it. But this is sort of the end result, and fairly looked good. And again, this was the way it looked. But at 45 days, this is now how it looks, and so this is very different. Now the Watchman is sort of sitting on its head, and so you can see that it's clearly not occluding the left atrial appendage, and the feet of the Watchman are kind of on the Coumadin ridge. So this is a little bit of a dicey situation. One, we're worried that this Watchman could come out, and two, those feet can certainly cause some damage. So here's another image of it. You can sort of see, I guess I'll play it again here, kind of see that 3D image of it, and it's impressive. This is what it looks like on CT. It kind of has this little apple look to it, very cute. But again, it's not doing what it's supposed to do, and at this point, we feel it's at significant risk for dislodgement. So the patient was sent for a device removal, and so the big question now becomes, what do you do? Do you take this patient directly to surgery and just cut out the appendage and the Watchman, or do you attempt to retrieve it percutaneously? And if you did that, what are the tools that you would need to do? So this was a case that I assisted my colleague, Dr. Horton, and the decision was that we were going to try. So we were going to try and do this percutaneously. We were going to do this in the hybrid room and have the patient completely prepped for sternotomy with the idea that if we were struggling, if things weren't working out well, we would just convert this to an open case and do it. TE was present, ICE catheter. Now we used an 18 French long sheath, and we decided we'd put an Agilis sheath inside that. In order to get some direction, but also in order to be able to pull the Watchman out. And we used the bioptome to grasp it. And we had three of us kind of working on this. Now, one of the things we learned very quickly was the 18 French long sheath. Once you put it in, the Agilis hubs, and you really can't control anything. So you have to actually cut that sheath. So now you're taking this sheath that we cut and putting that transeptal with the hopes that that's going to work. And so we're able to get transeptal, and we're able to start pecking at this, and you can kind of see that you can actually contact it, you can actually grasp it, and you can actually pull it. And so here's what that kind of looks like. And we'll go to the next. Oops, here's the next one. Yep, here we go. So you can try and get the device, and we were actually able to grasp it, but as we're pulling it, you can actually see the whole thing moving down. So it's pretty attached to the appendage. But we know that not all of the feet are attached because some of the feet are exposed. And so then we try to get the center of the device, maybe getting the center of the device, you could grasp it in a better way with the hopes that that'll work. And then ultimately we are able to grab it and kind of give it a gentle tug. And you can sort of see the heart moving with the tug, which is a little bit nerve-wracking. And again, we had the surgeon in the room, so nobody was taking any excessive chances. We had everything prepped and ready to go in case we had to convert this case. And here's where we actually get to dislodge this device. And so that was kind of the goal. If we could dislodge it, then the idea was maybe we could pull it out. Yeah, and so this was the first high five moment of the case where we dislodged it. But at the same time, it's the first pucker moment of the case, because now that it's dislodged, we have to make sure that we didn't tear the left atrial appendage. So immediately as we dislodge it, we're still grasping it, but obviously we're looking very cautiously and monitoring and making sure that there's no blood in the pericardial sac. And indeed there was none, so we felt very, very happy with that. So now we're going to try and pull it into the big sheath, and this is where we learned kind of lesson number one or lesson number two. As we're pulling it into the sheath, the device kind of pops back. And the reason is that the ability to grasp it is not particularly good. You can kind of see the device kind of jumping around the left atrium there. I'll show it to you again because it's fun. Yeah, there it is. You can kind of see it. This is what it looks like on a TEE. Kind of banging around, jumping around. So the challenge here is now we have to grasp it again, and the challenge is how do we hold it still to get it, and then also in doing that, how are we going to be able to pull it out? So it's not easy because this thing is banging around. It's a 30 millimeters, so we really don't want this to dislodge into the left ventricle. That would not be a good situation. What we did notice, though, is that at times it would kind of jump down towards the right inferior pulmonary vein and stay there, which we could potentially pin it down in that area against the septum. So you can see it's kind of like a video game here. But once it gets down there, things are a little bit more stable. So now we want to change strategies a little bit. The idea here is to pin the device and then get another transeptal and pull it out with the other transeptal, or pin it with one of the two transeptals. We had this idea that maybe we should put in a bigger sheath, so we ended up, if you're ever wondering if you can put a microsheath in the left atrium, the answer is with enough force and with a strong enough wire, yes, you can. I'm not sure I would recommend it, but that's what we did. And so the other thing, and this is probably the biggest lesson here, is the bioptome matters. So if you use a cardiac bioptome, it really doesn't have the strength to pull on these. And as you get into the sheath, as this device crumples, the bioptome will release it. So you actually need to switch to a GI biopsy tool. So the GI biopsy tool looks like this. It's like a monster. It's much bigger. It's good and bad. The good news is it grasps and it has enough strength. The bad with the GI tool is once you grasp, it's not easy to let go. So that's sort of the challenge with it. So here we are. Now you can see there's a microsheath in the left atrium, and we're holding down the device with one tool and then trying to grasp it with the other tool. And these devices do grasp very well, but again, these are fairly sharp, so you have to kind of be sure that you're not tearing tissue or opening them up and whacking them around when they're open. You kind of have to move them with a little bit of caution as you open and close them up against the device. And then this is the success. So now once we have a strong enough tool to hold this, we're actually able to pull the device into the 18 French sheath and remove it, and then obviously check the ultrasound. And this is the real high five moment in the case, because now we've got the device out, and the patient actually is doing great. There's no effusion. Everything looks good. And again, tribute to my colleague, Dr. Horton, who did the heavy lifting. And this is what it looks like when it comes out. So this is a mangled piece of junk. And, but this is what you expect, because as you pull this thing through the sheath, this is what you're going to get. So you really want to make sure that as you're pulling it, you don't lose this somewhere in the vasculature. You want to make sure you have a good grab on it as you pull it. So I would just summarize, then maybe get DJ's thoughts on the case. You know, recently implanted devices can be removed, but with extremely great care. And I think that I'm not sure I would ever remove a device if it was really fully in. But this one, the way it was sitting sideways, we thought it was maybe reasonable to try and just give it a little tap and see if it comes back. It's important to look at how they're engaged, and we did that. We looked at TE, we looked at CT, we looked at all the different things to make sure. If you do lose a device in the body, whether it's in the atrium, anywhere in the heart, in the vasculature, you need the GI forceps is what you need. The cardiac one is just not strong enough, and that was, I think, a really valuable lesson. And then obviously backup immediately available. We were in the OR room, we had the perfusionist was there, we had the cardiac surgeon in the room, so this is not something that I would just do. And with that, again, I'm going to plug EP Live for the next few years in Austin, India, Milan, and Latin America, and see if DJ or anybody in the audience has any comments or thoughts on the case.
No, I mean, this is a fascinating case. I would say for somebody like Rodney, who has done hundreds of these cases, this was probably a possible scenario. But I think if this was in the hands of a relatively less experienced individual who, I mean, doesn't have the feel for the tools and the device, I would say, I mean, it's pretty nerve-wracking. I mean,
yeah.
I mean, you walked out unscathed. That's amazing. That's wonderful. So I think if you reel it back, what is it that you could have done differently at the time of the implant? I mean, hindsight is always 20/25, and could we have done anything differently in that particular case? Were all the anchors like properly positioned, and was there a good amount, sufficient amount of compression, and was there anything that we could have done differently? Could have been sized a little bit differently? I think those are all the questions to ask. I mean, but again, the anatomy of this appendage is rather funny, because you see this big funnel-shaped appendage which tapers very quickly. It has a very wide ostium and a very relatively narrow mid to distal portion, and that really limits the options that you have.
Yeah.
So if we had access to an Amulet tool or Lambre or any of those other things, I think that would have been a better tool than the Watchman device in this particular case.
Rodney?
So Rodney, do you have any comments on it? I mean, obviously, we're commenting on this case without knowing what the dimensions were, and so you probably have a better insight into this.
When we looked more closely at the imaging from the original implant, the Coumadin ridge side probably wasn't as stable as we would normally have accepted. Of course, it's easy to say now, but I would say that from an anatomical standpoint, there's really no reason why a Watchman wouldn't have worked in this case. This wasn't a chicken wing. This wasn't a terribly shallow, really wide-mouthed appendage. So there isn't an excuse for this happening. Nonetheless, it did. And of course, we knew about this problem for about 10 days before we executed this. And right up until the device being pulled out of the ostium of the appendage, I was right on the fence about calling the surgeon to have it opened up. And then, of course, once the issue with the cardiac bioptome was it basically pinches the fabric. It doesn't grab. The GI biopsy device is absolutely terrifying to look at, and anything that you would describe as having fangs doesn't really sound like it is something that you would want in the heart, but it worked, and Amin was right. Once it grabbed onto something, you could pull anything in. Yeah. It was quite amazing. but it was also very difficult to let go of. So we used this particular device through both of the sheaths. So once we grabbed it, and we actually managed to grab it through the threaded insert, so the area where we probably could have pulled this into a 14 French sheath, I had a lot of trouble letting go with the other bioptome. So that was kind of one of the many oh shoot moments in this case. But we were debating. I mean, we called the surgeon and said, "Hey, what do you think?" Probably 20 times during this case. So we were very worried about doing this percutaneously. And until it finally came out, I was not convinced that we were going to be able to do it.
So Rodney, if you were to do this again, now that you know that the Raptor works better than the bioptome unquestionably, would you have not dislocated or dislodged the Watchman, instead just still keep it in the appendage, use the Raptor and then pull it out? Or
No, actually, I've thought about this a lot. So the reason we placed an Agilis inside the larger sheath is these larger sheaths don't have any deflectability. You can't control them at all. In fact, the micro is just a straight tube. And so you have to put something inside it that has deflection. But it doesn't have to be anything terribly large, because this Raptor and the bioptome, they're really small. I mean, they'll fit through a 5 French or a 6 French sheath. So in retrospect, we didn't need a 24 French sheath, because we frankly didn't pull it into the 24 French sheath. And in fact, if you could grab the threaded insert, you really didn't need anything larger than an 18 French. So in retrospect, I think what we would have done, if I had a do-over to do it, obviously this device was sideways. This was never going to endothelialize. It may not migrate, but it would always have had a risk of erosion. And of course, you would have still had to do something to occlude. I probably would have gone across with 2 18 French sheaths, so we had enough flexibility. Through them, we would have placed 2 Agilis. Through one of them, I would have used a bioptome, because you really didn't need the Raptor for both.
To hold it down.
And I would have grabbed it and dislodged it with the bioptome. And then with the Agilis, you could rotate it around and sort of present either the threaded insert or something that you think is suitable for grabbing. Then you could have controlled it, grabbed it from the threaded insert with the Raptor, then you're home free.
And you're home free.
And we would have only had to go across with 2 18 French sheaths. I mean, it's large, but at least then you're not leaving something that will likely require an ASD closure device. So
did you end up closing the ASD?
No, it probably still needs to be closed, but the patient, for some odd reason, doesn't want us doing things to him at the moment.
Did you re-implant, Rodney?
No.
The patient declined to reimplant.
This was, it was not the Flex. This was the original, 30 millimeters. So I mean, in retrospect, of course, it may have been undersized, it may have been too proximal, we could have gone with a 33. There's a million things you probably could have done, and we kick ourselves for doing. But as I've said earlier, you learn a lot more from your failures than your successes. If this had been a success, we wouldn't have been presenting it. It just would have been ho-hum, a windsock, pat ourselves on the back. This was a terrifying failure, but we learned a great deal about how to manage this.
So if you had, if this device were to be a little more distal, and if you had more of a proximal neck available, you think a minimally invasive mini thoracotomy or thoracoscopic Pro-V clip could have been a solution in that case?
It would have had to been a real distal for that, because if you had placed something like that on this, even if this had been a lot more distal, I am not at all confident that you would not have ruptured the distal end.
Perforation of the appendage.
Watermelon seeded the device out of the tip of the appendage. And of course then, if you've completely occluded it, you got away with it. But if there's any leaking, you don't have adequate exposure to deal with the emergency. The patient would probably die. So we were hoping not to reach that point. We were hoping to find some controlled solution where we think, okay, well, we need to go to surgery, sorry, but at least it's not in some extremist type situation. So I think I learned a lot from this. I wish I didn't have to learn any of this, but we did learn this.
Great.
Very
Well,
nice.
I think I'd like to thank everybody for coming and thank our faculty for joining us, and hopefully we'll see you next year.